Hello. Hello, everyone. Welcome to this webinar entitled Siud Meets the ICS. We're going to talk on non-antimicrobial intravesical treatment option in recurrent UTI. This is going to be a very interactive webinar, so there were no slide presentation, just question and answer. So I pass the word to Vincenzo Limarci to tell us on what guidelines say. Vincenzo, the floor is yours.
Thank you, David. Good afternoon, everybody. First of all, it's a pleasure for me to introduce and welcome you to this webinar created thanks to the collaboration between Italian Society of Urodynamics and International Continence Society. And also, I wanted to thank all the colleagues who agree to be part of the faculty. The webinar provides a new formula to propose a topic such as prophylaxis of recurrent urinary infections and includes a series of questions which our expert will answer. Finally, I'd like to thank the IBSA company for helping us offer this course. So let me introduce also Enrico Finazzi, Siud past president, with whom I share the moderation and the scientific organization of this webinar. Please, Enrico, we are ready for you.
Yes, Vincenzo, thanks for the introduction. Thanks for organizing this webinar. I'm very happy to participate to this webinar as past president of the Italian Society of Urodynamics and trustee of the International Continence Society. As David has already introduced, this will be a very quick, let's say, version of a webinar, because we will have a very short answer and hopefully short replies, short answers, short questions, sorry, and short answers to obtain at the end, I think, an enjoyable webinar with no long and boring lectures, but smart discussion of the topic. I think that now it's again your turn, Vincenzo, to introduce the webinar with the topic of the guidelines.
Okay. Good afternoon again. Let's start by looking at what the main guidelines recommend for the recurrent UTIs. These are my disclosures. I will mainly look at guidelines from the European Association of Urology and 3 North American associations, Urological, Canadian, and the Urodynamic Society. The European guidelines defines recurrent UTIs as recurrences of uncomplicated and or complicated UTIs with a frequency of at least 3 UTIs per year or 2 UTIs in the last 6 months. The American guidelines include the need for 2 urine culture in the definition of recurrent UTI. Recurrent UTI therapy is represented by antibiotics, and both guidelines analyze the self-start treatment. Starting antibiotic therapy without urine culture can be considered for compliant patients in case of acute recurrent episodes. But prophylaxis is the real cornerstone approach to recurrent UTIs. Continuous low-dose and post-coital antimicrobial prophylaxis for both European and American guidelines have been shown to reduce the rate of recurrences. Furthermore, most physicians are aware of the problem caused by antibiotic resistance and prefer alternative methods for prophylaxis. In considering a non-antimicrobial prophylaxis, we can recognize behavioral modifications, vaginal estrogen in postmenopausal women, and immunative prophylaxis that is effective in reducing the number of UTIs according to European guidelines only. Continuing with the non-antimicrobial prophylaxis, we find probiotics that are useful for restoring vaginal flora, or even the use of cranberry recommended by associations, but current scientific evidence is divided. We can also use mannose, useful for preventing UTI in selected patients according to the European guidelines, while methanamine epurate is recommended by neither guidelines due to lack of data, but according to the latest study, this product is not inferior to current standard care in preventing recurrences in women. Concerning endovesical instillation, European and American guidelines indicate that glycosaminoglycan endovesical treatment reduce the frequency of recurrent UTIs and increases the symptom-free interval. The latest edition of the European guidelines recommends using endovesical instillations of hyaluronic acid or a combination of hyaluronic acid and chondroitin sulfate to prevent recurrent UTIs because it is less invasive than other preventive approaches. In conclusion, and in accordance with this review published in August 2022, we can say that to date, the misuse and overuse of antibiotics are major problems. And also the clinical evidence confirms that gag therapy is a valuable approach to prevent the recurrence of UTIs episodes. Thank you for your attention. And now I give the floor to David to start asking questions to our experts. Thank you.
Thank you, Vincenzo, for this nice introduction. The first question is forwarded to Dr. Emmanuel Chartier-Castles and Philippe Banquero. The question is, what is the prevalence of cystitis, of recurrent urinary tract infection, and prevalence of female versus male patients in your clinical practice? So the floor is yours, Emmanuel first and Philippe after. Emmanuel?
Yes, I just switched on my microphone. Thank you very much, David, for your question. Your questions, there are many questions within the question, and we start sharing with Philippe, female and males. For female cystitis, I would say that for your basic cystitis, not recurrent, one on third woman may have one episode of cystitis in her life, so it's very frequent. Recurrent UTI in women, we don't know exactly the epidemiology, but it could be 3 to 5% of those who suffered non-recurrent cystitis in the past. And definitively, the prevalence is not so well known. It's a disease which is more known and more linked with GPs, and good epidemiological studies are not really available. And definitively, this type of cystitis has to be well evaluated with GPs. Probably, Philippe, you have some data for males? I'm not sure.
Well, exactly. My answer on the precise question would be, I have no figure, no exact data, nor on prevalence, nor on incidence. But it was an important part of my practice. And I can divide this in 3 types of patients. Patients with neurological conditions, which is a specific entity when we talk on urinary tract infections. Then indeed, as you said, females and males. And I consider them not only from anatomical perspective, but also from urinary tract infections completely different. Another point that I want to make concerning my practice, since I was working in a secondary referral center, I mainly saw indeed patients with complicated or recurrent urinary tract infections. And for the majority of these patients, it was bad treatment that was causing their persistent infections, more than the microbial resistance or whatsoever. So I think this is important when we later will discuss non-antimicrobial treatments for recurrent urinary tract infections. that the first problem is not additional treatment, but make the exact diagnosis and see what are the risk factors, why this individual patient has had this infection and why the infection has been recurring.
And to conclude on that topic, I would like to come back on the issue of the asymptomatic bacterial urinary lysis, because we will not speak about it anymore. But first, we have to say to the audience that any patients who suffer asymptomatic bacterial urinary lysis doesn't have to be treated. And we know that 25% of aged female patients may suffer asymptomatic bacteriuria, and we must not treat them.
We can summarize that we treat the patient and not the urine.
Absolutely.
Thank you, Emmanuel, and thank you, Philip. Let's move on to the second question. And this question is first for Professor Chartrier again, and then for Professor Montserrat Espuña-Pons. What are the main exams you recommend for the diagnosis of recurrent UTIs? And further, do you routinely perform a cystoscopy before? Please.
As I have to start to answer, I will start with the history of the patient. I take a lot of time to come back on the history of the first cystitis, the reason why patients suffer new symptoms, which treatment have been done, the full story of bacterial analysis to check which type of bacteria is present. Is it always the same? Does she suffer some resistance because she had some self-prescribed treatment, which is a bad habit of a lot of patients. So full history is time-consuming, but it's absolutely mandatory to palpate the way the patient is suffering symptoms related to bacteria which are present in the urine. And so probably now we may have some more comments about the cystoscopy and the full diagnosis we may do with other examination like ultrasound examination. Please.
Good.
Good. Professor Montserrat, please.
Open the microphone.
Can you open your mic?
Open your.
Excuse me. Yeah. Okay, so as commented Emmanuel, the story is a key point. But inside the story, I think that the tailored symptom assessment, at least in women, it's very important because acute dysuria is a key symptom in bacterial cystitis at any age of women. But in older women, there is an overlap between the symptoms of overactive bladder, for example, and urinary tract infection. So it's very, very important to analyze the symptoms. And also we, as a gynecologist, pelvic examination, it's very important. So we perform, in the initial evaluation of a patient who is studied for recurrent urinary tract, we always do a pelvic examination to evaluate the signs of vulvovaginal atrophy, also signs of prolapse and signs of urinary incontinence. All of these are risk factors for urinary tract infection. Also, because we use perineal ultrasound in all gynecological patients, so we measure a post-void residual because it's only a couple of minutes to see if there is any residual in the bladder, asking, of course, before the patient if has gone to the toilet before. And I think this is all. There's also the microscopic urinalysis and a standard urine culture with sensitivity to the antibiotics it's key for us. It's still a criterion of a standard for confirming suspected urinary tract infection in women. No, we use that. And we agree that, and according to the guidelines you presented before, Vincenzo, it's in acute episode of women with recurrent urinary tract infection, we usually treat without waiting for the result of the urinary culture, no? But we always perform that. in all patients who are studied for recurrence. We only indicate cystoscopy if a woman is at risk for a suspected foreign body inside the bladder or the urethra. I mean, the main reason in our practice who can have women with this could be some kind of a small piece of mesh inside the bladder or others. Only in these cases, but we don't perform cystoscopy in all patients we evaluate for recurrent urinary tract infection.
So as a urologist, to conclude this part of the session, we cannot escape the fact that we will ask patients avoiding diarrhea. We will check the voiding phase and the storage phase. And even if we check if there is no residual urine, we have to check what are the habits of the patient. Are they used to have a normal voiding and relaxed voiding? And what are their usual habits?
Yeah. I agree completely.
May I ask something? I would like to have a quick reaction on the other panelists, because something very dear to me in the history taking, definitely in females with recurrent urinary tract infections, is asking about their toileting position, because we know that the majority of women never sit down on a toilet, and it's definitely a risk factor for post-void residual, and hence the need to discuss toileting position, which is rarely done, I think. But I would like to have the opinion of the other panelists.
Yeah, I agree, Philip. That's true, and that's also a risk for voiding this for increase of post-void residual, which might be related to recurrent UTI.
And extension to that also, I think in terms of diagnostics, we need to have a flow of at least post-void residual measurement after micturition.
Yeah,
exactly. It's what we call voiding habits checkup, which is absolutely mandatory.
But in patients with recurrent UTI, in my practice, sooner or later, I would perform a cystoscopy, looking for a foreign body, particularly if the patient underwent previous surgery for stress urinary incontinence, just in risk of tape erosion or extrusion. So let's move to the next question. Forwarded to Julio, Monse, and Jansen. So are there specific endoscopic findings for you to look for?
Hello, everybody. First of all, thanks to the chair and organizing to invite me. And my opinion, and also as the guideline says, cystoscopy is not usually recommended for the initial diagnostic workup in recurrent UTI. And if you look at guideline, the recommendation is weak just for select patients. But it may be indicating some complicated conditions, such as a painful bladder syndrome if the patient refers pain to exclude any suggesting pattern of interstitial cystitis, for instance, glomerulation or under culture. Or when outlet obstruction is suspected in men with primary or secondary bladder neck obstruction or BOO, just to document the stricture or see the status of the diffusor, and if there is any sign of hypertrophy or diverticula, maybe not voiding diverticula, that can give a risk for UTI. Of course, cystoscopy in chronic cystitis may be potentially give some information about the mucosa, such as the presence of Brown's nest, cystitis cystica, squamous metaplasia, or leukoplakia of the trigon. But which is the real clinical significance of this endoscopic feature is still unknown, since they have also been in several healthy and asymptomatic women. So, of course, if the patient referred to have cystitis with hematuria, endoscopic assessment is very important, just to exclude if there is any oncologic sign. But I can conclude that usually, if there is no any abnormality in anatomical abnormalities or dysfunctional or hematuria, we avoid in our clinical practice to perform endoscopic examination. Please, with the next.
So I absolutely agree that this is the objective, or the thing that you look for when you are indicating a cystoscopy. But I want to consider that in our unit, and I think in many units with gynecologists, as you know, we are very, we use ultrasound very often in all our pelvic examinations. So we are very used to measure. So in our practice, always in these patients, we perform ultrasound, and we see suspicious of anatomic abnormalities. And then if we see that, we perform a cystoscopy to complete the diagnosis. No, but I think ultrasound is an important instrument and is not invasive. No, so in that kind of patients, I know there is not any evidence to support that, but it's only practice of years and years using ultrasound in these patients. So when it's like a screening, and then when we suspect that there is an anatomical defect, like diverticulum or bladder tumors or stones or a foreign body, because we have found inside the bladder an immigrated intrauterine device even, or other strange things, as all of you I suppose. So in ultrasound, you can see very easily that, and then you confirm with endoscopy in these cases.
I have all of the above. I think there are very good suggestions for cystoscopy, and I think they're so standardized. So I also look, when you look at the bladder, I look at the cobblestone effects, trigonal edema, those kind of things, anything that's signs of inflammation. The other thing I really have to add is that I really, but before I introduce my scope, I do, like Dr. Montserrat also said, to look for any signs of vaginal atrophy, and also signs of prolapse that I do before I do the cystoscopy. And I pay special attention when I introduce the scope, because I like to evaluate the urethra, not on the way back only, but also on the way towards, because you can have cystoscopy effects on the urethra once you introduce the scope. And I pay special attention when it's abnormally painful or very difficult to introduce, or there's any signs of inflammation, of course, in the urethra before I enter it, because often when you already pass the urethra and then you go back, you already see some signs of your cystoscopy. So I try to evaluate both on the way towards and the way afterwards, and especially look at the patient as well to see if there's any abnormal reaction to pain or any signs of pelvic floor overactivity. So that's basically it.
Okay. So we can conclude that we do just in select case, and ultrasound is a good guide to decide if go on, and also the history of the patient.
I would like just to point out that for when we suspect bladder pain syndrome, interstitial cystitis, cystoscopy should be performed under general anesthesia to evaluate the bladder capacity, and also, of course, look at whether or not the patient has Hunner ulcer, but not in recurrent urinary tract infection, as has been said.
I agree with you, David, and also in case if the patient refer not only recurrent UTI, but also he has pollakiuria, high frequency of micturition, and a small bladder capacity. Maybe overdistension can help to improve their symptoms.
I think especially be aware when there's complaints and symptoms without positive urine sediments with nitrate. So then I'm extra aware that it may be bladder pain syndrome. I do consider also do cystoscopy just without anesthesia as a first checkup. You can see 100 lesions there very well also. But if I really suspect that I cannot confirm it, and I still suspect there may be bladder pain syndrome with inflammatory signs, then under anesthesia is recommended. But I don't think it's always needed, actually.
Yeah.
I would support that, and additionally, it will give you a limit. What is the bladder capacity when pain comes up? So I think that's also important information, also in the rest of the treatment that we will discuss later.
Yes.
Thank you. I'll give you the fourth question to Professor Montserrat Espugna and then to Professor Del Popolo. What are your first line suggestions for the patient with recurrent UTIs? Please, Professor?
Well, this is I think that takes a lot of time. I mean, I spent a lot of time in the first visit of a patient with recurrent urinary tract infection to try to comment some aspects about that maybe there are not evidence for that, but I have seen in my life with a lot of experience with these patients that education is very important in this first contact, because first of all, it is about vulvovaginal atrophy. If I have observed in the physical exam that there is a vaginal atrophy, I spent a lot of time explaining what atrophy is, what important is to treat atrophy, not only because, as you know, atrophy, it's changed the vaginal microbiota, and also is demonstrated that also has an influence in urinary microbiota. So I try to explain how important it is to have a healthy microbiota in the vagina, and how important it is to treat atrophy. Not only for that, even for women, atrophy, it's, as you know, is a cause of dyspareunia and a cause sometimes of microtrauma that can produce reinfection, and is another cause of urinary tract infection. So taking this aspect in premenopausal women, I used to ask what kind of sexual habits they have. Of course, it's impossible to go very, very deep, but at least I try to say which habits it can be, I don't know, risky for that. Because one thing is what people see in the imagination, or in the some special I know, films, and they want to reproduce that. And this, for young and old women, sometimes it's a very strong relationship, at least in my experience as a gynecologist, many years of experience with urinary tract infections. No? And additionally of that, even if there's not evidence, I recommend to drink a minimum of 1/2 liter of liquid per day, try to urinate frequently, fight constipation with healthy diet, use neutral soaps in cleaning the genital area, using cotton underwear, and avoiding tight clothing. I think this is very important for young women with recurrent urinary tract infection, and also consider the use of diaphragm as anticonceptive, as a contraceptive, or the use of tampons during the menstrual period. These all are, in complicated cases, these are things that we have to consider and to try to control. No? And also in summer, don't wear for a long time the wet swimsuit. This is another important, as you know, humidity in this area change completely the vagina atmosphere, and can create or alteration in the microflora, no? And I think this is more or less the aspects. But I spent a lot of time, because as you all have know and have experience, they are complicated patients. They are very anxious many times, because the impact of these infections in their personal life is very important.
Please, Giulio.
Yes, thank you. I think that Professor Ponce said all. But first of all, I like to use a bladder diary just to empower the patient and self-monitor and tailor the proper fluid take, considering the negative habits. For instance, stop drinking late evening to avoid the bladder or distension during the night. Recommendation to regularize also the bowel function in a constipated patient. For example, we notice in female with a neurogenic bowel constipation, a reduction of UTI, improving bowel voiding using transanal irrigation. And this is a clear relation between bowel and the bladder regarding UTI. We give some recommendation about pelvic perineal hygiene, and also we give some advice to use during sexual activity, because as you know, postcoital UTI are very frequent and is a big problem for this patient. At the same time, we give also some other rules, and this depends also from some individual factor and possible comorbidities, such as in a patient with neurological bladder and they manage intermittent catheterization. So give some rule to avoid to have cavity, to have a UTI related to catheterism. And at the same time, obesity, excess intake of caffeine, alcohol, also some time of sport like cycling or horse riding that may worsen the storage urinary symptom. All this is something that is very important on my mind because one pill can't solve the problem of UTI, but is some general change in lifestyle.
Thanks, Giulio, for this for your point. And so now it's my turn to pose some question. I hope that we are lucky because Ferdinando Fusco was able to join us a few minutes ago after a difficult plane travel. Actually, I think that Nando is with us. Probably cannot turn on the camera, but I think he's able to reply. So Nando, if you can hear me, I would like to.
Yes, I can.
Wonderful.
Yes, I can.
Welcome. You're really you're able also to show your face.
Yeah.
To
I'm
the
still on the
audience.
plane, but I can do it.
Okay, wonderful. So Nando, I will be the first to interact with you. And the question that I would like to pose to you, and then I would like to pose the same questions to Philip and to Emanuele. And the question is, if you prescribe, I want to know if you prescribe antibiotic prophylaxis and if you believe in the use of long-term antibiotic treatments in non-responders to, let's say, conventional treatments.
Yes, my answer is yes to both questions, because I do rely in continuous antibiotic prophylaxis, and I think that it can be used as a long-term treatment. I'm not very worried about antibiotic resistance, because in my experience, it is quite worse to start and stop antibiotic treatment, especially if you use a short period of treatment and little dosages, while women successfully treated with the continuous prophylaxis may stay on treatment for longer period without developing antibiotic resistance. Of course, this is a last short treatment after other non-antibiotic treatment have failed, and the woman must be very motivated to do that. However, it's something I use quite often. Regarding the postcoital prophylaxis, I'm a little bit less positive. Postcoital prophylaxis might mean a lot of things. First, many women have postcoital problems, but sexual activity is not the only reasons for them for triggering infection. They report infection after sexual activity, but also other infections without sexual activity. Also, if you ask the frequency of sexual activity in these women, sometimes they answer you that they have a low frequency of sexual activity. So postcoital prophylaxis is good, you think, because you can administrate 1 dose per week, might be, or antibiotics. But if the prophylaxis is effective, the frequency of sexual activity might increase. So at the end, these women take 2, 3, 4 dosage per week of antibiotics. So in that case, they could be better be served with a through continuous prophylaxis, which in my view, in terms of antibiotic resistance, is less dangerous than postcoital prophylaxis.
Thanks. We have understood your point, even from the plane. Philip, do you want to comment on that or give your opinion?
Initially, some comments that are relevant to this question. For many things that we discuss concerning urinary tract infections and definitely recurrent urinary tract infections, there is very little evidence. And also the guidelines, therefore, are not giving us always an answer what to do. So there is a lot of, you can call it improvisation, or it can be based on personal experience, and then it comes to tailoring to an individual patient. So there is no general answer, I would say. Another point in terms of prophylactic antibiotics is what we mean with antibiotics, because there's clearly a difference. For example, in the Netherlands, what is very popular in terms of prophylaxis is nitrofurantoin. That definitely does have not or very minimal risk to creating a resistance, and is a nice tool that eventually you can use for prophylaxis. I would be more reluctant with, I would say, the other antibiotics, because still there is a risk of infection, and we see increasing resistance to the classic antibiotics that we use for urinary tract infections. Definitely those antibiotics that have a good penetration into the tissue, because that's an important element when there is a chronic or recurrent infection. We do not speak of a number of bacteria in the urine, but there is inflammation. There is also niches of bacterial content in the wall of the bladder that could create long-term problems, and therefore necessitate the treatment indeed with antibiotics that penetrate good in the tissues. And then we're talking on ciprofloxacin and that type of antibiotics. Another important remark is that we have to realize that when we prescribe prophylaxis with antibiotics, that the use of the patient is not always as we would hope and expect it to be. Some studies have indicated that only 1/3 of the patient indeed buy the antibiotics and use it on a regular basis as we indicated them. 1/3 buy the antibiotics but don't use it, or don't use it as we prescribe it, and 1/3 even don't buy the antibiotics. So also in the evaluation of the effect of prophylaxis, we have to take into account and perhaps interrogate and ask the patient if there is a failure of long-term treatment, if the failure is not linked to not using the antibiotics or using the antibiotics as we prescribed it. As I said before, I think again, before any prophylaxis with antibiotics, the major question is, did we do enough in terms of diagnostics? Are we not missing the diagnosis here? Are we not missing causative or co-causative factors before embarking on chronic antibiotic use? Because still there is a risk of resistance and failure of therapy because of that.
Philip, I agree with what all you have said, but and I was.
I'm so happy, David. Thank you.
Yeah, I used to prescribe nitrofurantoin, but for since a couple of years there is a warning relating the use of nitrofurantoin with pulmonary fibrosis. That's why I'm more concerned to do it nowadays.
Yeah. Well, then again, this is another aspect of antibiotic prophylaxis. Is this antibiotic prophylaxis for a couple of weeks, maximum of 6 weeks, or is this of 3 months, and so on? So definitely the risk of fibrosis will increase with the long-term usage of antibiotics. And indeed, some patients will use it on a very long term. Indeed, I would be very reluctant to have it on a long term, because the major idea behind prophylaxis is to prevent that there is sufficient bacterial count that can reinfect the bladder. Now, this effect should be there at a certain moment when the bladder has been healed from previous infections, that the natural resistance of the bladder has been restored, and hence it has no sense, unless there are specific risk factors, to go for very long prophylaxis, even with nitrofurantoin, and definitely with other antibiotics.
Thank you.
Dick, do you want to say? Sorry.
We are running out of time, so I will have a final comment about resistance.
Yes.
I am used to use 3 months alternates antibiotics, what we call a cycling of antibiotics, and low dose. And such a way you alternate, and I don't see any resistance if the patient is following this schedule. Those who suffer resistance is because they have antibiotics prescribed by GPs with too high dose and too long-term the same antibiotics prescription. So definitively patients have to be educated to follow the alternate antibiotics and low dose. And even if they do their own choice because of tolerance, or side effects? Should they have alternate antibiotics every month for 3 months? They will decrease the risk of resistance.
Yeah, I agree with your point, Manuel, and also I agree very much with the point by Philip that of course antibiotic prophylaxis cannot be forever, should be for a certain amount of time to restore the capacity of the bladder to have a self defense against the infection. I think that Dick wants to add something to this topic.
Yeah. Also regarding this, also how do you, my colleagues here, recommend age as a main factor of prescribing, especially long-term antibiotics? Because I get a lot of 20, 30-year-olds with lifelong antibiotics. Sometimes also years of antibiotics, which I don't agree on, because it doesn't fix the problem. It only extends it. And I would say, well, you still have many, many years to go. We cannot keep you on antibiotics forever. So how do you think about prescribing long-term antibiotics, like half a year, or even more than that?
Yeah. Philip is putting down his thumb. I think that I agree with him, and also it's what we were commenting before. I don't think that prophylaxis can last forever or for a very long term. Probably we should use this prophylaxis to help the bladder to recover. Of course, we have some patients with damage for chronic infection in the bladder, and so we have to restore this situation, and then we should stop the prophylaxis. I think that we
also, Enrico, we're going to discuss other treatments that could prevent this long-term.
Exactly, and this is why I would like to stop here this discussion and give the word again to Vincenzo, who should go on with another question, because we are running a little bit out of time. And also I would like to say to the audience that some of them are posing questions. If we have time, we will answer those questions at the end. If we don't have time, we will try to answer by email or in another form. Vincenzo, please.
Well,
David,
I thought this was my turn. Thank you.
Sorry.
Thank
David,
you,
sorry,
Enrico.
not Vincenzo.
The next question is for Dr. Giulio Del Popolo and Dr. Jansen. The question is, what is your experience with non-antibiotic prophylaxis? Which product do you use? Dimanos, Urovaxum, Cranberry, hyaluronic acid, or oral or other?
Thank you, David. In my clinical practice, I have used all different types and dosage of Dimanosio, but also Urovaxone, the oral vaccine for E. coli infection, Cranberry, hyaluronic soft oral pills. But my impression is that after temporary short term of some benefit, patients discontinue the treatment for poor satisfaction in terms of UTI recurrence. Maybe only people with spinal cord and neurological bladder or multiple sclerosis use for longer time. By now, there is poor evidence in the choice of these supplements, and this is good to recommend one rather than another. And often the patient who has been addressed to the specialist, to me, by the CP has already tried at least one of this treatment, and those it's very hard to convince her or him to try another one. Usually in about 20–30% of complicated cases, I am still using a low dosage of antibiotics, or French people, Emmanuel and Pierre Denis, teach me the WOCA system. That means low dosage and alternate and different antibiotics just once a week. And really, I have a good result with low resistance. But all these kind of treatment, in my mind, can be very important because it's hard to convince patients not to treat asymptomatic bacteriuria. And between one UTI and the other one, they have a lot of asymptomatic bacteriuria. And the recent study on microbiome demonstrate, for example, that there are some types of Escherichia coli that defend the organism from Pseudomonas aeruginosa infection. So the use of no antibiotic prophylaxis for long time, not for a short time, in this case, not mean only to reduce the antibiotic resistance, but also not to destroy microbiome, that mean good bacteria against bad bacteria that lead to infection. This was my experience.
I can further comment. I always try to explain to a patient that most patients that come in are more often secondary referrals and so on. So I see quite some bad cases. And I was explaining to them it's like a weighing scale, and we have to put just the right amount of weights on the right side of the weighing scale to make sure that bacteria cannot grow enough anymore to cause urinary tract infections. And I'll just see what's on hand. And I think the EU guideline, the update, is quite informative because it gives you evidence. Because my patients often come with a lot of products that there's no evidence whatsoever for. So I try to guide them in this. And the EU guideline gives you now some good advice on this. So firstly, I always postmenopausal women, estrogens local, if it's possible, or not contraindicated. I have a preference for Dimanos compared to cranberries, because cranberries products are there's a wide variety in what's in it. I cannot confer on, I cannot control this. And there can be cranberry juice with just 1% cranberry juice in it. As for Dimanos, it's a compound, and you can actually see how much you are taking in. So that's why I have a preference for Dimanos, because I can actually control this a little bit better with my patients instead of cranberry products. The Urevexom is not available in the Netherlands. It is in Belgium and in the Netherlands and in Germany. The evidence is quite good. It's recommended now in the EU guidelines. So I really want to get access to this for my patients, because it's as a vector of the immune system that we're not treating at this moment. And finally, the probiotics, I was a bit confused with the EU guideline because it has a similar 1B recommendation, but instead of the Urevexom with the vaccinations, the immunotype of treatments, they got a strong recommendation, whilst with the same level of evidence of 1B probiotics get a weak recommendation. So I didn't understand the reason behind this whatsoever. So in my opinion, they're sort of similar, and I try what. Of course, this costs a lot of money for a patient. So I try to guide them. You can do this, and I cannot look into their wallet. And I think it's quite a shame that it's very easy to describe cheap antibiotics, but all these types of things a patient really has to pay a lot for themselves. So that can be problematic, actually. So this is actually, the way I try to see what's possible for a patient. I try to guide them in the right products that have some evidence behind it, even though there sometimes is a weak recommendation in the guidelines. So that's basically sums up what I recommend for my patients.
Thank you very much. We should move to the next question. Vincenzo?
There is Professor Montserrat.
Oh, sorry.
Only 10 seconds to insist in the importance of to treat vaginal atrophy. Please, this is very, very important. Long time of experience with that. And it's for me, in a postmenopausal woman, you have to think that all postmenopausal women have vaginal atrophy after 5 years of amenorrhea. So all they have vaginal atrophy. So when you start antibiotic prophylaxis, please combine with vaginal estrogens. It's very, very important. Only that.
Very good point, Monse. Thank you.
Thank you. Thank you so much. And now this 7th question is first for Professor Montserrat and then for Professor van Kerbroek. When do you consider intravesical agents in patients with recurrent UTIs? Please.
Well, I have to say that we don't have very much experience with intravesical agents, and as you have, urologists, but in some cases, we have indicated this treatment mainly in women with recurrent urinary tract infection that failing repeat oral antibiotic treatments. And of course, in that case, it's an alternative treatment modality in this high risk of patients, no? When we don't have any positive response to the systemic treatments. And also, another possibility is in these treatments, at least in my experience, could be useful in some kind of radiation-induced cystitis after treatment for gynecological cancer. And this is another possibility that I think this is an important area to try to promote, in my opinion. I don't know what Philip thinks or what you as you think, but I think this is really an important area to promote because it would be very useful.
Again, there is a general approach in a sense that we agree that there are patients where we're not able to really cure them from the recurrent infections. So where even with additional conservative means, there is a problem. Even when there is correct diagnosis, there is no risk factors or the risk factors have been eliminated. So there definitely is a need for additional treatment. However, that is bringing to a lot of problems. First, there is no evidence in the literature that intravesical treatment has a significant effect in all patients with these problems. Probably in some patients there is the case, but even that is not proven. So that is already, let's say, an ethical or medical legal dilemma that we have to face when we decide to apply these therapies. That second problem, as a consequence of that, is that, and it has been mentioned before, that starting such an intravesical treatment necessitates quite financial effort from patients. So in a system where there is no reimbursement and patients do not have a private insurance that allow them to have this, it's quite an expensive treatment. And so that will limit the indication and the application of this therapy. A third general factor is that catheterization is necessary. And so in patients that have already this history of long-term bladder problems, pain problems, infection problems, to start with a therapy with intermittent catheterization will need some talks to convince them that eventually there is a possibility to ameliorate their situation. Having said that, when can you consider it? Well, when you're, they say in Dutch, with your hands in your hair, if you still have hair, that means I don't know anything. I did good diagnosis, I did good therapy, and still this patient has problem. Then you can propose this intravesical therapy, even with all the problems that I quoted before.
Thank you, Philippe. The next question is entitled, what are the intravesical treatment you use for Philippe van Kerreve and Dick Jansen, please? Philippe, what are the intravesical treatment that you use?
Yeah, I will leave the floor for more specific answers to Dick because he knows much more about this than I do. Just a general framework again. There is no evidence that there is a major difference between the different intravesical treatments. So you can choose for whatever. You can say, well, there is a nice person from a company. I like the company because they have a booth on the ICS, on the EAU meetings, or whatever reasons you can invent to have a preference for one company. And these are important elements. But purely from a medical point of view, for the time being, there is no indication that there is a major difference between one treatment and another treatment. But perhaps Dick will say something completely different now.
Thanks, Philip. I usually, well, most studies have been done with a combination of hyaluronic acid and carnitine sulfate. So, and also when I look at a compound point of view, also some of the products available have some higher concentrations in them of the working compound. So that's why I use the combination of both. But again, they have never been compared to one another, so we don't know. There's two trials now starting. One's already ongoing in Switzerland, and the one I'm actually starting is now started in the Netherlands, actually comparing the combination treatment gag therapy against the other arm is just a nitrofurantoin daily doses for a year follow-up to actually find an answer to this whole thing. And I think we have to wait the results of these two trials to see what happens finally if when it is compared to gold standard antibiotic prophylaxis. That's the only way we can actually show this to in the future. And from a basic science point of view, we can actually see now in our own lab that it actually does something on urothelial repair. And that's also quite something because that's been evidence quite lacking beforehand for decades. So we actually see that it also induces urothelial cells to heal faster. But again, it's the whole picture combined, and it doesn't say anything about urinary tract infections or bacterial and so on. But again, this is what I use. And if that fails, gag therapy in patients when they have like high, side effects from antibiotic prophylaxis, for instance, or they're very young. And if that doesn't help enough, I sort of consider from basically on the Dutch guideline to use gentamicin installations as well in simultaneously or separately to see if we can combat it any further. But these are last resort cases that are immune to all different prophylactic treatments and so whatsoever. So,
would you confirm the following statement? The best choice for intravesical treatment is the one that works in an individual patient.
I'm very much agree to this.
Trial treatment with one treatment, and then at a certain point in time, and the next question will address what is the point in time, the patient is better, the infections are gone. That was the optimal treatment for that individual patient, because I think there is an individual susceptibility of a patient for a specific treatment. I
completely agree. It also goes with antibiotic prophylaxis. Evaluate in time, and you have to wait a little bit. It's not like, okay, in the first month, because when you have 3 urinary tract infections a year, it can happen in the last 3 months, 3 times, or it happened in the first time. So you need a couple of evaluation time. I usually use about 4 months to 6 months to see if a proper therapy works, yes or no. But if I see that after after gag therapy, they end up with heaps and heaps amount of more urinary tract infection also in the beginning, like 4 or 5 or continuous, then I stop it.
Thank you very much. Enrico, would you like to make any remark? Hello?
Yes,
Enrico?
sorry, I had my microphone muted. No, I have nothing particularly to add, but I think that Dick and Philip raised the good points. First point by Philip is that the evidence is lacking, unfortunately, in that field. And on the other hand, what Dick stated, that probably the most studied combination is hyaluronic acid plus chondroitin sulfate, and so probably this is, let's say, what we have studied more, and the agent that probably is more used at this moment, at least in Italy. I don't know, probably also in Europe. But to come to again a practical question, I would like to ask again to Dick and also to Ferdinando Fusco. What is your usual treatment schedule, and do you use maintenance installation? So how do you start your treatment, and how do you maintain effects, if any?
You want me to start?
Yep.
All right. Well, basically, I want to first say there's no dosage finding study whatsoever done on gag therapy. So we just wing it, which we tried it before, and that's how it seems to work. But I think there's a lot to be gained on looking at this type of dose finding study or dose efficacy studies to require, because it's still a lot of places non-reimbursed. So it would be nice if we have a sort of a lower frequency dosage scheme and so on. So that's my first remark. But therefore, I just use the same thing as we use more commonly as we use in bladder pain syndrome or ICBPS, is 6 week, once a week dosage, and then I continue with a once a month dosage, and I continue with it. If it works, I continue with it in that once a month. I try, even if it works, sometimes to really stall it to even once every 6 weeks and so on. But if it goes well, I try to stop it every once in a while to see how the bladder is repaired and how it goes. But I must admit there is some relapses often when you stop using this as a prophylactic treatment. So so you have to take care of all the other things that might risk factors and so on, to see if you can get the system working better and reduce all the risk factors as much as possible without using as little as possible antibiotics. Because that's in my patient cohorts the main problem, because I do see a lot of people with long-term problems, been on many antibiotics, been in many resistance patterns and so on. So that's how I have a bit of a filter function and a bias on that, because I see much more severe cases on this. And so I often have patients on gag therapy for quite a long time because they're very happy with it, even in a low frequency dose. Yeah.
To reduce the use of antibiotics.
And one more remark maybe is that when they have a UTI, I give 2 or 3 times once a week an upregulated dose because they have an inflamed bladder again. So I just give them sort of the upgrade after urinary tract infection, after the antibiotic course. Yeah.
Thank you, Dick.
Okay.
And Nando, do you want to comment that
Yeah,
differently?
very shortly on my side, no much difference. I encourage patients to go on with the maintenance treatment for, if possible, 1 year. I think the longer the better, but sometimes this is not possible. They might have no money for that because the treatment is costly. And also the catheterism, these are not neurogenic patients, these are normal women, and then they can complain about the discomfort of catheterism. However, if the balance of the woman is positive, I encourage do not give up with the treatment before 12 months overall. This is my short comment.
Thank you very much. So the last question is, do you think that combination treatment, for example, intravesical plus oral treatment, may work better? This is for Ferdinando Fusco and Emmanuel Chartier. Please go.
Yeah, of course, I do not suggest a combination treatment two different administration routes of the same molecule. So I do not use, for example, hyaluronic acid administered intravesically and at the same time oral hyaluronic acid. But we can combine a different active principle, for example, hyaluronic acid and mannose, D-mannose. This might be possible. So I don't think there is much literature about it. Combination treatments is very empirical, and if the single treatment should be better patient-tailored, also the combination even more should be patient-tailored. Probably patients have tried many things before arriving to endovesical treatment. Among the non-antibiotic treatment might be some of that have provided some benefit, and she can be encouraged to continue with an oral active principle, for example, D-mannose in my experience, when she starts with the endovesical administration of hyaluronic acid. This might be a good combination, even if it's not evidence-based.
Answering this question, I guess we have to make a specific concern for neurogenic and non-neurogenic patients. Those patients suffering neurogenic high pressure and long-term contaminated bladder, they are challenging patients, and they may be part of some protocols dealing with oral and intravesical therapies. But as a general concern, when we discuss oral and intravesical therapies, we have to know if we speak about oral antibiotics and non-microbial therapies intravesical, or non-microbial oral and intravesical therapies, which is not the same. And so, as I know, and outside of any recommendations or guidelines, we have absolutely no high-level data which may give a full answer to this question. We all have some patients who had some specific, I would say, attempt to combine treatment, whatever they are non-microbial or microbial specific. But we cannot make any final conclusion with such individual cases. So I would be very careful. I'm sure there is a place for randomized controlled trials, and probably it has to be done in non-neurogenic patients first, because neurogenic patients, they combine so many risk factors for acute symptomatic urinary tract infection that it will be confusing to make any conclusion.
Have any one of you ever heard of the use of intravaginal yogurt to trying to change the pH of the vagina?
Yes. With our infectiologist in Garches, we discussed it also for neurogenic patients, but we didn't use it. We could speak also about vaccine therapies, which are not available in all countries, which may be of interest, but it's outside of the last questions. So there are a lot of issues to look for the future.
Yeah. Vincenzo, you want to comment?
Vincenzo, before you start, I just want to let you know that we have some questions from the audience. I think it will be difficult to answer all of them. The first one is about urethral transposition. I think that I can try to answer this question. I think this is a surgical procedure that has some stories, especially coming from Russia. So the many studies were done there. Actually, I think it's not in the recommendations, in the guidelines. So I have nothing to comment. It's a possibility to try to increase the distance between the urethra and the meatus of the vagina, but I think that there is very few evidence for this surgery. I would like to try to ask a specific question to Emmanuel, if possible. Another question is about recurrent UTIs in patients performing intermittent catheterization. Do you have special instructions, special suggestions for those patients, Emmanuel?
Yes, for those patients, as it has been said by Giulio in this meeting, we are used to use weekly oral cyclic antibiotics therapy, and we are rather happy with it, and we don't see any resistance with a long-term use. What we don't know is if it's this therapy has to be used 3 months, 6 months, 1 year, and to be stopped, or to be a continuous one for the long life treatment. So there are also remnant questions. But the weekly oral cyclic antibiotics is a good therapy we use for those patients using self-catheterization, well balanced in terms of bladder management, and still suffering symptoms related to bacteria inside urines.
Thank you, Philip. Thank you.
One small additional comment. Sometimes these patients with recurrent infections and intermittent catheterization, they have been increasing the frequency of intermittent catheterization to a very high level because they have complaints, and so they increase it, and then decrease in the instruction that they should not increase the frequency of catheterization may be important and stay below 6 per day, for example.
Yeah, completely agree. I would like to ask you, Philip, to remain online. There is a question coming from Alessandro Giammo, who is the Vice President of the Italian Society of Urodynamics. And the question is about any dietary advice for patients with recurrent UTIs. What do you think, Philip?
Yeah, indeed a great question where I have to give an answer that is pure based on experience and without any evidence. Clearly, some aspects of food may definitely influence complaints. Very hot spices, typical, for example, in the Netherlands, Indonesian food, patients will say that they have much more complaint, and there's no direct relation with infection. So dietary measures definitely can have a symptomatic effect. Then the most important dietary instruction in patients with recurrent infections is water. And then they can choose Belgian water, which is the best in the world. But I think any form of water without too much chemicals would do well. But then again, it's an important point is to instruct patients that they should drink enough water to have about 2 liters of urine production per day. And how much they have to drink will depend on the time of the year, on the physical efforts they do, but that's very important. Another thing is to motivate patients to drink enough water. And there is a very important instruction to make, I think, is to say to patients that they have to have at least 2 liters of water ready in the morning, and they should have finished it in the evening. Then more or less, on an average, they will reach at about 2 liters of urine production per day, which is the best prophylaxis of infections.
Thank
please,
you. Dick, please.
Yeah. Also an extra comment, because I see also these young girls that they either drink a lot of water, which is good, but also the other girls that actually don't go to the toilet at all. And I say bacteria need to grow in a couple of hours, and the longer you postpone voiding, the more time the bacteria have to exponentially grow. So I also say, especially also in the older patient cohort, so not the others, but the very older ones who don't feel or sense their bladders as much anymore, I would say timed voiding can often help with some voiding instructions, actually, because it's, in my opinion, with enough intake, output timely, that can also help in my personal experience. But the time voiding there's no evidence for that whatsoever. But it makes sense, of course, because bacteria needs to grow and it needs time to grow, and the longer it takes to grow, you have between voids, the more time it has to grow into a bladder. So that's from a biological point of view, it makes sense. So.
Okay. Thank you. Thank you. I will kindly ask to David to give us some conclusions, a short take-home messages of this webinar.
Thank you very much, Mrs. What has been a very interesting debate. We know that the prevalence of recurrent UTI is not well known. So obviously there are some differences between male and female, but globally speaking, generally speaking, there's no good data. So I would like to highlight the fact that asymptomatic bacteriuria should not be treated unless several circumstances. One of them is pregnancy. Obviously, the workup should start with proper clinical history, with urine culture. Cystoscopy is not mandatory in the initial workup. Of course, it's essential when we suspect a foreign body or interstitial cystitis, but as Montse Espuña highlight, ultrasound is essential part of the armamentarium for the diagnosis. So the first line management, of course, is conservative treatment. As Philippe remarked, the increase of an enough amount of liquid water, particularly Belgian water, is essential part of treatment, because not only for UTI but also for stone disease, it's important to drink enough amount to pass at least 2 liters per day. Regarding prophylaxis, there are several forms of prophylaxis, but I think that most of the faculty is in favor of doing rather continual rather than the intermittent prophylaxis, although several forms are acceptable. And in addition, there is not much evidence suggesting or determining which one is better. Finally, intravesical therapy seems to be a good option for those patients who do not respond to the standard treatment. The aim is to restore the gut layer in the bladder. There are several options, either combining hyaluronic acid with chondroitin sulfate, or any one of those as monotherapy. Theoretically, the combination is better than monotherapy for intravesical instillation, but there's no head-to-head study comparing one with the other. So I think that's most of what we have discussed, which has been very richful, I think.
Thank you, David, and thank you all. See you to the next meeting, and thank to Natalia Trotta and the 4 staff for technical assistance. Thank you again.
Thank you very much.
Thanks, Vincenzo. Thanks, everybody. Goodbye.
Thank you, all of you.
Goodbye.
Thank you very much, all of you.
Bye.
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 Thank you.
Bye-bye. Thank you.
Goodbye.
Bye.